Very good afternoon, viewers. Once again, I am back, your host, Dr. Shobhit Seth from Integrace Gynecology. And yes, it has been a long time that we have been disconnected on the webinars. It has been a month when we had our Origin program along with the international faculty from FIGO. And here we are again. And now we are going to take it ahead. We are going to present a series of webinars on vulvovaginal infections. And we have named it as the VVI Times, as you all are aware of. And we have got now, just to brief you about my organization, well, it is ranked among the top 85 companies in India, and it is 13th in the gynecology represented market. And then we are trusted by 42,000 Indian doctors, and 5,000 gynecologists patronize our products. We are leaders in 2 therapy areas, that is ANC care, progesterone and Hemagenics, along with products for VVI infections. Now, as you all know that today we have a panel of esteemed guests from the North Zone, and we have Dr. Alka Sen, who is from Agra. Madam is a chief consultant of Sen Maternity Hospital, and she holds the record in the Manorama book for delivering a 100-centimeter female 5 times by cesarean section. And she is holding prestigious positions in the NGOs like the Rotary Club, Bharat Vikas Parishad, and Aradhna. She is the chairperson in Torrent Power for protection of women against sexual harassment at workplace. Welcome, madam, to you. It's a pleasure to share the platform with you today. Now, we have got Dr. Nisha Jain from New Delhi. Ma'am is head of the Department of OBGYN in Saroj Super Speciality Hospital, which is in Rohini. And she is internationally trained obstetrician and gynecologist, having an expertise in performing MIS and handling infertility. She's a gold medalist in MD Medicine. She's a FOXY certified gynac endoscopy surgery trainer. She is founder and president Northwest Gynac Forum from 2000 till date. She is a fellow guide for Dawn DGO and actively participates in all the leading conferences in OBGYN across the Indian contingent or the Asian contingent. Now I have got Dr. Supriya Jaiswal from Patna. She's a chief consultant of Dr. SM Hospital. She is a specialist in the government hospital and treasurer for POGS 1920, chairperson Adolescent Health Committee POGS, communicator ISOPAR National, treasurer IFS Patna chapter, and special awards and recognitions what madam has achieved, the Dr. MP John Gold Medal and Dr. GVLN Murthy Award for the best paper in obstetrics, gold medal for best short paper in gynecology. So I welcome Dr. Nisha Jain and Dr. Supriya Jaiswal for being a part of this webinar series. And thank you very much for accepting our invitation at such a short notice. It is always a pleasure to be with you on the platform and get engaged with the doctors who are stalwarts in their field. So thank you very much. And I request Dr. Alka Sen, madam, to please start with the official proceedings of the webinar. Thank you.
Thank you, Dr. Shobhit, giving the introduction of we all 3 gynecologists. And thank you for making me the part of this webinar. And we are going to speak on a very common and very irritating condition. And it is not very serious, but the symptoms are so irritating that there are the changes in the personality of a woman, and that is the vulvovaginitis. Vulvovaginitis, it is actually an inflammatory condition of the vulva as well as the vagina. As a result of there is a discharge, itching, pain, dysuria, and at times dyspareunia. So all the symptoms, it is the collection of very much frustrating condition. And this condition recurs naturally. The recurrence of this condition is too much, it's too high. So we should see what is the cause of the recurrence, what is the cause of this inflammation, can we prevent it? or if we can prevent it, what are the measures for the prevention? So basically we are talking today for the prevention and no doubt for the treatment also. So we should see that this vulvovaginitis, the cause of the vulvovaginitis can be of lot many reasons, maybe fungal, maybe viral, maybe bacterial, maybe trichomonal infection, and maybe mixed. And there are a little bit a very small differentiation in all the discharges and all the inflammations. At times there are fungal and the bacterial both. So the clinician has to see very keenly the symptoms and the clinical examination to go for the treatment. At times it happens that we feel that we are treating a fungal infection and we are giving anti-fungal, but it is a trichomonal infection. So the patient is very irritated and she always complains that I'm not getting the relief. At times I have seen in my clinical practice that the lot many patients used to come and they say that I'm having UTI. And it is a very confusing term that we are not examining, we are not taking any symptomatology, and we are treating her as a UTI patient and she is not being relieved. So my message to you all people is that we should not be hesitant to take the total complete history, symptomatology, and the clinical examination. Both the speakers are very learned and they are going to speak on the symptomatology, the sign and symptoms, and the diagnosis and the treatment. And we have got a good interactive session. We invite the question to give the answers by my learned speakers, Dr. Supriya and Dr. Nisha. And I think it will be better that we go in the brief for the description of the vulvovaginitis, and then we will have the interactive session of the vulvovaginitis question answer. So I invite Dr. Supriya Jaiswal for the brief introduction of the vulvovaginitis infection.
Thank you, madam. Thank you. And I thank the organizers also for giving me this opportunity to talk on this subject, this very important subject. So shall I start my screen share?
Yes, Dr. Supriya, you can start.
Yeah, but not getting to share. Can you see the slides?
Yes, yes.
A very good evening to all of you. I start before you the perineal wash for better vulvovaginal health. So, vulvovaginal infections. The current scenario is 3 in 10 women suffer from VVI and 20% of them experience recurrence. VVIs impact women in every walk of life and are in dire need for daily intimate hygiene in all life stages. Women are very hesitant to discuss their intimate hygiene issues, and one of the few people they trust is their own gynecologist. So, vaginal pH imbalance can occur at any stage of a woman's life due to various factors and leads to intimate problems. Lack of intimate hygiene could play a role in many vaginal infections, which is caused due to alkaline pH in the vaginal region. So, the problem is the intimate feminine hygiene. Is it cosmetic? No, it's not. Lack of hygiene in the private parts could lead to irritation and itching, burning sensation and dryness, malodor, white discharge, and vulvovaginal infections. So, there are also a number of vaginal infections like that could arise due to Lack of intimate hygiene. There are also a number of vaginal infections that could arise due to a lack of intimate hygiene, like bacterial vaginitis, candidiasis, trichomoniasis, mixed infection, non-specific vaginitis. So the need is to educate. Lack of awareness of personal hygiene of intimate areas and a trustworthy listener and limited available options. So vulvar skin is different from the other part of the body. Like sanitary napkin test, if you do, sanitary napkin soaked piece of sanitary napkin in normal saline attached to upper arm versus vulva. After 2 to 4 days, you can note no dermatitis on upper arm, but vulvar dermatitis in all the volunteers. So we conclude with this finding differences in epithelial characteristics exist between vulvar skin and the rest of the body. So perineal skin is acidic due to acid mantle. The optimum pH of human skin is 5.5. A fine film with a slightly acidic pH on the surface of the skin that provides protection for the skin. It contains lactic acid, various amino acids from sweat, free fatty acids from sebum, and amino acids and pyrrolidine carboxylic acid from the conification, that is keratinization process of the skin. So supports the formation and maturation of epidermal lipids and therefore the maintenance of the barrier function. It provides indirect protection against invasion by microorganisms. It also provides direct protection against alkaline substances. So these are the average pH value in different phases of life. pH value of women's vaginal area is in newborn is 4 to 5, girls is 7, puberty age it is 5 to 7, childbearing age amounts to 4 to 5, then pregnancy 3.5 to 4.5, and menopause it is 6 to 7. So it varies. So, factors which disrupt the vaginal ecosystem are external and internal. External, we have poor perineal hygiene, soap or bubble bath pH or more than 7, deodorants, antiseptics, too frequent use of towels, wearing of synthetic or tight clothing and underwear, pads, shaving, oral sex. The internal part is puberty, pregnancy and following childbirth, menstruation, and menopause. Lack of hygiene, it is an invitation to VVI. So, in private parts, irritation, white discharge, itching, and dryness. This bacterial vaginosis, candidiasis, mixed infection, trichomoniasis, and non-specific vaginitis can be detected. So, disturbed vaginal ecosystem leads to increase due to increase in pH. There is an overgrowth of pathogenic bacteria and detrimental to survival of lactobacilli. So here is a summary of signs and symptoms of infective causes of vaginal discharge. So in case of bacterial vaginosis, the discharge is thin. In candida, it is thick white, and trichomoniasis, it is scanty to profuse. Odor also, first it is offensive, then non-offensive and offensive. Itch, in bacterial vaginosis, there's no itching, but in candida, you feel the vaginal itch, vulval itch, and even in the trichomoniasis. So visible signs, you can see the discharge coating the vagina and vestibule in case of bacterial vaginosis. And in candida, you don't find such symptoms. You cannot see these findings. So these are the differences. Even in the case of pH, it is more than 4.5 in bacterial vaginosis. And in candida, it is lesser than that. And same with the trichomoniasis. So vaginal ecosystem, the vaginal protection system is based on the maintenance of a 3.5 to 4.5 acidic pH. The origin of vaginitis and vaginosis lies in the breaking of the acidic pH, acidophilic bacteria, high metabolism, lactic acid production, acidic pH, vitreous cycle. The recurrence rate is high as medicines treat the overgrowth of symptoms producing pathogen converted saprophytes without taking into account the restoration of the physiological vaginal ecosystem. Protection against the pathogen growth is based on the presence of a large number of non-pathogenic saprophytic bacteria in the vagina, which avoid the presence of unwanted microorganisms. These bacteria are generally known as the Doderelins bacillus in honor of Albert Gustav Doderelins Sigmund in 1841, who first described this presence of vagina in 1892. So, a low and acidic pH is generally considered as the primary mechanism for maintaining the composition of a healthy vaginal microflora. Indeed, most lactobacilli thrive best at a pH less than 4.5, which clearly justifies its designations as acidophilus or lovers of acidity. The characteristic pH of women of reproductive age, that is between 3.5 and 4.5, is achieved thanks to the presence of a sufficient amount of lactic acid in the vagina. Lactic acid is synthesized in the vagina by Lactobacillus acidophilus, obtained from pyruvic acid through a glucose fermentation mechanism. So the physiological state of acidity is reached thanks to the following landmarks. Ovaries produce estradiol, the multi-layered epithelium of the vagina. Vaginal mucosa proliferates thanks to estradiol, which also induces the glycogen loading of these cells. Vaginal epithelial cells gradually flake out in the vaginal lumen, and desquamated cells undergo a lytic process which allows the release of glycogen contained in them. So glycogen is metabolized through acidophilus bacilli via anaerobic fermentation, that is without oxygen. The main waste product resulting from glucose anaerobic fermentation is lactic acid, which is, as mentioned, the cornerstone to acidify the vaginal environment. Now, vaginal ecosystem, you can see the table that estrogen leads to glycogen, lactic acid, acidic pH. This promotes the growth of lactobacillus acidophilus and growth of inhibition of the pathogens. So this is a vicious cycle produced in the vagina in physiological condition. So this is according to the normal physiology. So hydrogen peroxide, the synthesis of hydrogen peroxide is related to the presence of lactic acid because the hydrogen ions of the lactic acids react enzymatically with oxygen to produce hydrogen peroxide. This product, widely used in the medical field as an effective disinfectant, has a negative impact on microbial species with no catalase enzyme which destroys this molecule. Without deeply harmed and they end up dying. Logically, the catalase enzyme is a part of Lactobacillus acidophilus, which makes them immune to hydrogen peroxide. So, bacteriocins. So, vaginal lactobacilli produce several specific antimicrobial substances with a peptide structure. Such substances are referred to generally as bacteriocins. Lactocin and crispacin are two examples worth mentioning. Many studies have shown that a low pH favors the activity of bacteriocins. Therefore, the presence of lactic acid is also somehow involved in the mechanism protecting vaginal health. The vaginal ecosystem undergoes major compositional changes throughout a woman's life. From childhood until puberty, the limited presence of estrogen implies a low bacterial content in the vagina, which occurs during reproductive years. On the other hand, during menopause, as estrogen levels drop, not only the epithelial fragility of the vaginal mucosa is affected due to the decrease in the thickness of the different cellular layers, but also the vaginal flora due to the decrease of lactobacillus acidophilus, which depends on the presence of glycogen to survive. Therefore, the vagina loses much of its self-cleaning ability and natural defenses. Coming to the factors influencing the vaginal microbiota. So, menstrual cycle is one of them. During menstruation, the vaginal environment is less acidic. pH is 6 or more because the menstrual blood tracks the lactic acid present in the vagina. Furthermore, lactobacilli drop in number because they bind to the erythrocytes of menstrual blood instead of remaining in the epithelial cells that cover the vagina. Therefore, menstruation becomes a risk factor for the maintenance of vaginal ecosystem. which explains why many women often refer to non-specific vaginal discomfort after their menstruation, which is secondary to the deficit of lactic acid and lactobacillus acidophilus. These symptoms will persist as long as a woman is unable to recover the level of vaginal acidity before menstruation. Coitus. The sperm has been shown to act as a powerful alkalizing agent which reduces vaginal acidity within a few seconds and keeps the vagina neutralized. During several hours after intercourse, to facilitate spermatozoa enter into the female reproductive organs. Due to the neutralization of the vaginal acidity, sperm which poorly tolerates the usual acidity of the vagina gets protected, and pathogens finding alkalinity suitable for colonization can also take advantage of it. Therefore, because of the presence of semen in the vagina, natural protective mechanisms are neutralized. This can explain that why many women suffer from vaginal discomfort after periods or frequent sex relationships due to the alteration of the vaginal microbiota rather than to friction or mechanical factors. So coming to hormonal contraceptives, the use of contraceptives with very low or no levels of ethinyl estradiol causes a state of relative hypoestrogenemia, which disrupts the production of glycogen and therefore of lactic acid. Consequently, these women are particularly susceptible to alterations of the vaginal ecosystem with resulting discomfort. Breastfeeding. So during breastfeeding, the amount of estrogen is relatively low because the ovaries need a few weeks to recover their full functions. Therefore, the situation is the case of low dose estrogen hormonal contraceptives. So use of intravaginal products such as showers with antiseptic or soap products which deeply alter the vaginal ecosystem as they drag lactic acid and lactobacillus acidophilus, which help reach a non-acidic pH. Although this problem can be specially emphasized if alkali products are used for dosing, these are not a requisite for the vaginal ecosystem to be altered, as too frequent hygiene more than twice a day is sufficient to modify the condition of the vagina. So now coming to the use of antibiotics, the action of antibiotics not only destroys pathogenic organisms but also causes a decrease in the good microorganisms of our body's natural flora, lactobacilli acidophilus, as well as much of the intestinal flora are sensitive to broad spectrum antibiotics, especially beta lactams. For instance, the use of some systemic antibiotics can justify the appearance of more or less severe diarrhea. Similarly, it justifies vaginitis caused by candida, as fungi are not susceptible to antibiotics and they are therefore not affected by them. Whereas lactobacillus acidophilus are in fact, before starting an antimicrobial treatment in women of reproductive age, all physicians should know that the biennial antibiotic treatment, Candida vaginitis, is very frequent. Chronic stress. Chronic stress favors the production of large amounts of steroids, mainly cortisol, which in turn have a negative impact on multiple systemic structures. The vagina is one of these structures that it is a place where reached by adrenal corticosteroids, which alter the growth of lactobacillus acidophilus and the production of lactic acid. So this is the vicious cycle. It is shown in the table form. This produced in vaginitis or vaginosis. Two confluent aspects. In a woman diagnosed with vulvovaginal candidiasis or bacterial vaginosis or a non-specific vaginitis, the treatment should be the decrease in the pathogen quantity and the recovery of the vaginal pH. Most clinicians, only the first part of the treatment is necessary, we think, that is the reduction of the elimination of pathogens. As the vaginal pH must be recovered to prevent relapse, it is necessary to restore favorable conditions so that lactobacillus acidophilus, which do really protect women from the recurrence of new infections, can proliferate and develop. Therefore, Probiotics have been recommended for quite a long time as adjuvant therapies to the use of fungicides and antibiotics. How can a vaginal acidic pH be restored after pathogens have been removed or reduced? Lactic acid is the most physiological, authentic antiseptic as it ends the bacteria, prevents the proliferation, and favors the growth of Lactobacillus acidophilus. By providing lactic acid to the vagina, the clinician avoids depending on the action of the exogenous probiotics administered, thus eliminating a problematic step. As long as the amount of lactic acid and the acidic pH are insufficient, the environmental condition will not favor the proliferation of saprophytic bacteria and their metabolic activity in the vagina. This table shows ways to break the vicious cycle where you put the probiotics and lactic acid to break this cycle so that lactic acid and the natural vaginal flora can be maintained. Lastly, it should be remembered that the topical administration of lactic acid in the vagina does not involve any risk because it is a natural and common substance of the vagina. It is highly recommended to the use of hypoallergic liquid cleansing agents with mild detergent effects and acidic pH ranging between 4.2 and 5.6. While lactic acid-based liquid with low pH have been shown to augment skin hemostasis and helpful in cases of genital infections as an adjuvant therapy. So here strong scientific rationale is shown by the RCOG guidelines. It shows that the recurrent treatment regimen and the recurrent infection. In case of bacterial vaginosis, there is a suppressive therapy. Oral metronidazole 400 milligram twice daily for 3 days at the beginning and end of menstruation. Metronidazole 2 grams stat dose monthly. Intravaginal metronidazole also can be given. Then lactic acid gel 5 ml tube at night for 2 to 3 nights after menstruation or once or twice weekly. This is the treatment options. For VVC also induction, fluconazole capsule 150 milligram every 72 hours into 3 doses. Maintenance is fluconazole capsule 150 milligram once a week for 6 months. Then alternative maintenance is clotrimazole pessary 500 milligram once a week and fluconazole capsule 50 milligram daily. Itraconazole capsules 50 to 100 milligram daily and ketoconazole capsule. These are the treatment options. And for this one, we can exclude vomiting with metronidazole and repeat standard regimen as above. So this is the strong scientific rationale that helps in treating the infections. Strong scientific rationale for MACA guidelines is guide on female genital hygiene. Women of all ages require daily intimate hygiene to keep their genital area clean. The vulva is susceptible to contact dermatitis. Take care to avoid contact with irritants. Use a hypoallergenic liquid wash with mild detergency and pH 4.2 to 5.6. Avoid bar soaps and bubble baths, which are abrasive and have a more alkaline pH. Lactic acid-based liquids with an acidic pH may augment skin hemostasis and have been shown to be helpful in vaginal infections as an adjuvant therapy but not as a treatment. Vaginal douching is not recommended. Wear loose-fitting cotton underwear and minimize wearing tight clothes. Change underwear frequently. Do not use talcum powder. Use any perfumes and deodorants sparingly. Change tampons and sanitary pads frequently. Before and after intercourse, clean the vulva from front to back, especially the clitoris, the vulval folds. Do not cleanse the vulva vigorously or irrigate the vagina. Use a safe method of pubic hair removal and take care to avoid sensitivity and scarring. Postpartum care should include frequent cleansing, drying, and using pads as necessary. Maintain dryness over any sutures. Do not use any creams. Wash hands prior to children's genital care. Use separate towels. So personal hygiene treatment of recurrent vaginal discharge in bacterial vaginosis is personal hygiene measures can be advised for women who are prone to vaginal discharge and those who are not
Hello. I think Dr. Supriya's internet connection has some problem.
Yes, I also feel so.
So I think she was in the end of her talk only.
So we can go forward.
Yeah, I suppose.
We can't
Madam,
contact.
Madam, you can take over.
Okay, I think there is some problem with Dr. Supriya. So I now.
Yeah, I will connect with her also. I'll connect her, and you, in the meantime, you can please take over. Yeah.
Okay. So Dr. Supriya has very nicely introduced and she has very nicely presented the total condition vulvovaginitis in a very nice way. And she has told that we should do a lifestyle modification, that we should not use any tight clothes. The undergarment should not be of synthetic, they should be cotton, and we keep the private parts dry. That is the take home message. And secondly, we advise the patient to take a good hygiene during menstruation, after delivery, and after having the during the lactation, because postpartum period is that period which is having a long bleeding time. So for the prolonged bleeding, that invites the lot many infections, and in that period we really need a good hygiene. So now I hand over the session to Dr. Nisha Jain. Dr. Nisha Jain, are you here? Are you hearing?
Yeah, I've come. Yeah.
Okay. Dr. Nisha Jain, I want some clinical experience on the condition vulvovaginitis, please.
Yeah, thank you, Dr. Alka. And we had nice presentation and discussion by you. And you rightly pointed out the patient normally comes and presents with a complaint as if she's suffering from UTI.
Yeah.
Normally, we are not the primary physician. The patient goes to 2-3 places, gets a urine culture done, and comes with a sterile report. She has gone to many gynecologists or general practitioners. So here we should not forget one thing, the ABC of the patient examination, because most of the time we physicians, we miss the examination part. So whenever patient comes with a problem, पेशाब की जगह खुजली हो रही है, पेशाब में दर्द हो रहा है, पेशाब में भारीपन हो रहा है. That's our normal complaints we get from these patients. So we have to be specific, asking them what exactly they are suffering. Are they having any discharge? Is there any past history of discharge? Right. So we get an overview of the history, and then examination is a must. Local examination of vulva, per speculum examination, and PV examination. Only by examining the patient in say 60 to 80% of cases, we can always make a diagnosis. Either it's a mixed infection, candidal, trichomonal, or bacterial vaginosis. But there are cases where a visual inspection may not suffice. We may think it's one infection and we find out it's another one. So my usual practice is when I get the patients of recurrent vaginitis or patients who have taken multiple treatments are not getting cured, I do an high vaginal swab. It's very frequently done in my OPD. Around 10 swabs or OPD is being done. And what are the reports? Even in a normal looking vagina, normal looking cervix, where the patient has complained, we find Klebsiella, we find E. coli, and we find different forms of fungi, mixed infection. And in this HVS, we do gram staining, culture, wet mount also, and fungal culture. In wet mount, so many times it's been reported trichomonas. They can see the trichomonas flagellata. So after doing this high vaginal swab, we can specifically give the treatment whatever is needed. At times when we get these, this is really strange, we get Klebsiella and E. coli, and in these cases we get the partner also investigated, semen culture and urine culture, and around 20-30% of the cases we find that the partner is also suffering. So here comes the need to prevent recurrent vulvovaginitis or PIDs. We need to treat both the partners. And when we treat them, so many times patients are happy. Secondly, this jet, which has been invented by some Indian engineer, brilliant engineer, which has been used in Indian toiletries and available everywhere, this is the most dreaded culprit, I would say, because everybody uses that jet. So we need to educate them, don't use this shed. They have to use a shower with the anterior to posterior washing. That's very important, because I had patients from multiple societies where they had this, they removed all these jet, and all those patients have stopped coming to me. So they are healthy. So this is very important, because from where the Klebsiella would go into the vagina or E. coli would go into the vagina, that's very strange. So I think this modernization has increased the number of patients with vulvovaginitis.
Yes.
So that's an important point. We need to ask our patients and to educate them along with the prevention. And I think that's the important thing I would like to say. Rest of the questions, whatever would come.
Yeah, very nicely presented, Dr. Nisha. This is absolutely a daily routine practice. And all of our gynecologists, they are getting a lot number of cases of vulvovaginitis daily. And, the patients, they are having vulvovaginitis, they are very much anxious and anxious looking faces. Because though it is a very, very common and very superficial problem, but it really goes to their heart, because they are not able to sit properly, because they are not able to have the sex life with their husband, and they are always feel like they can't sit in the society because they are instincting, because they are having the malodor. So this is absolutely a change in the personality. And I've seen the ladies, they feel as if some phoda has been broken and they are having a very serious problem, or they might be feeling like that they might lead to the cancer. So this is the, this is the myths amongst the patient. And, it is very difficult to make the patient understand that it is a very common and a normal condition. And if you will go for some prevention and lifestyle modification, you will be okay. But at times I have seen, Dr. Nisha, that many people used to go for hysterectomy. They are having the vulvovaginitis, and in the periphery I have seen that they have been done the hysterectomy for this only. Have you seen in your practice?
No, I had patients from say Patna or from like Eastern UP who had come at 30 years of age, 26 of age, got hysterectomized. And they still had their problems on. Like, this is really, really a very, very bad scenario. And in fact, I had an old Mataji from somewhere around Patna, and she was having milky urine. Urine absolutely of color of milk. And we got her tested, and it was tubercular cystitis. And we gave her TT and she was fine. And so many times it's tuberculosis. It's not vulvovaginitis, it's tuberculosis, genital tuberculosis, which again leads to this itching and discharge. So that has to be also kept in mind while treating our patients.
Okay. So I think we have enough discussion for the vulvovaginitis. I have some questions, Dr. Nisha.
Yeah.
Can Dr. Supriya is on the line? She's with us or not?
Unmute yourself, Dr. Supriya.
Yeah. Suddenly the net went off. I don't know, but then I came back. I rejoined.
Okay, thank you that you came back. And I think you have listened when you are not with us. You have listened the discussion.
Yeah, almost.
Okay, fine. So I have some questions. The first question to Dr. Nisha. Dr. Nisha, what do you feel like that the patient used to ask that we should have the vaginal douche regularly or not? What do you say regarding that?
First of all, the thing is, how do they do this vaginal douche?
They do with the cane of the enema.
Oh
I
my
have
God.
asked. Yeah, they have
My
got
God.
a.
No, this is absolutely no. This should not be done. Of course, it will wash away the keratinized cells and the lactobacilli, and this should not be recommended at all. Although some may not agree with me, whenever I had these patients of Klebsiella and E. coli and sensitive to gentamicin or amikacin or maybe meropenem, in those cases, the patient is really in a very bad shape with PID. We give douching with maybe amikacin and with a distilled water for some time, maybe 2-3 douches, so that the infection washes off, and then thereafter we can give the pessaries containing lactobacilli. So that's a treatment part, but the patient should not be doing douching on their own. That's bad.
Okay, along with that question, I want to further extend my question that people used to say, like women used to say who is having the vulvovaginitis, they say that we have cleaned our vagina with a lot of Savlon and Dettol.
Very bad.
And even then I'm having this infection. Why it is so? I mean, this is a very natural saying from the patient.
Yeah, we get patients saying that they have done that perineal wash with the Savlon and betadine and all those things. So that's where we need to educate. Whenever a patient comes in the OPD, although they are very heavy at times, but we need to educate our patients that this is not to be done. That area is very sensitive. No antibiotics should be applied in that area unless and until indicated for some skin infection. So it's a big no.
It's a big no. What do you say, Dr. Supriya?
Definitely yes. So they shouldn't apply these direct irritants, because the type of skin is very different in that area, very sensitive. So they shouldn't apply at all. Usually they say, you are very correct in saying, they'll say ki we used Savlon and even betadine and Dettol. They have so much of irritant they use, and they say ki still we are facing the same problem, but we have to counsel them. We need to counsel them.
Okay, because I think the Savlon and Dettol has become a regular toiletry of most of the women nowadays. Yeah. They feel that they are using antiseptic, and this is the height of the cleanliness and hygiene.
Absolutely.
Another question to Dr. Nisha Jain, that during this vulvovaginitis, can a couple plan for the pregnancy?
They should not. I normally prohibit them from planning pregnancy until the infection is taken care of. Because if the patient is still having vulvovaginitis and she say conceives and the baby goes fine, these are the patients who land up in threatened abortion. These are the patients who land up in preterm labor. These are the patients who land up in IUGR and oligoamnias. So with all these situations, conditions facing later on in pregnancy, it's better not to plan pregnancy when they are suffering. When both the partners are free from the disease, they can go forward and plan for the pregnancy.
Okay, Dr. Supriya?
Yes. In this case, usually, since this is a short-term treatment, we don't require 6 months treatment, so we can hold on the timing of pregnancy, planning to get pregnant. So we can stop, we can first treat the infection, let her be better. We can even treat both the partners, and then when they are fine, we can plan the pregnancy. They can counsel them.
Dr. Supriya, again, I would like to extend my question that if by the way the pregnant lady gets vulvovaginitis, then what is your plan in the first trimester?
See, in the first trimester also, we plan to give her the most of the perineal washes. We'll we'll ask her to do the local treatment. First trimester, usually I prefer to avoid any sort of antibiotics. So we'll try to counsel them regarding the hygiene, regarding the perineal cleanliness and keeping the area dry, take good food, good nutrition, and keep absolute hygiene. We better not try her prescribe some antibiotics in that time, unless she is in too much of distress. That is what usually what I do.
Okay, Dr. Nisha, I want to ask the question. These vaginal suppositories, do you prescribe during first trimester of pregnancy?
Oh, yes. Whenever we see, we do a perspectivum examination and we find out there is an infection and what kind of infection it is better to give them vaginal pessaries than not to give any treatment. And if the problem is severe, again, I would say we do an HVS, and according to the HVS growth pattern and the gram staining, accordingly we give them pessaries. We don't give any oral treatment, but local treatment can always be given to avoid any complications in future.
The pessaries and the wash is the first line of treatment.
Yeah.
Okay. Then another question is, how can we prevent the recurrences? Because the vulvovaginitis is such a difficult condition that it recurs a lot. And this recurrence is very much painful and very much distressing and very much stressful for the patient and the couple as well.
Absolutely. So here the first thing is to treat it completely. When there is an incomplete treatment, it would come again. So, and treat both the partners. As I said, we are doing high vaginal swabs in this patient where we get growth. After we think that the treatment is complete, we redo a high vaginal swab. If that comes normal, if Dodlin's vacilli is present, then only the treatment finishes, not before that. At times, patient may have to take treatment for 2 to 3 months, and fungal infection resistance is coming. When we get the culture report, most of the cases are fluconazole resistant. Only amphotericin B, which comes most of the time. So we have got amphotericin B gel and amphotericin injections for douching. That's all we do, and later on we give the lactobacilli after the infection is over. I think, as per my view, this is the only way we can stop the recurrence.
As you say that we should treat the both partners simultaneously, and I have seen in many cases that the husbands are reluctant to take any treatment because they say that I'm not having any problem. This is the problem of my wife only. Why I should take the treatment?
There's where comes the importance of counseling. We have to tell them your organ lies outside. You don't have any problem. You won't experience any problem. But your wife is suffering. If you love your wife, get your test done. And I make a situation like this that when he goes back home, he has to get it done. Or I write on the prescription, husband is not willing. I'll not be responsible for the treatment of the wife. Like, it's somehow you can get into their brain. You can get into their brain to get it done, either emotional blackmail or some legal blackmail. So they do it.
I mean, this is again a counseling part, and this is very important to prevent the recurrence that the husband should also take. So I want to ask one thing, Dr. Supriya Jaiswal, that if we are treating couple, I mean husband and wife both, so how long the husband should take? Till the wife should take that times, or he should take only a single dose therapy?
No, according to me, the doses should be complete for both of them. He should cooperate and he should also finish the full dose that is prescribed by the doctor. And as you said, we really need to counsel them. They need to know when they, apart from the female part, he has to also cooperate with the female, and he has to also take the complete dose, because incomplete doses of antibiotics gives rise to recurrence. Usually we should complete the dose. So I'll definitely counsel him that you should also take the full dose. Again, your wife will suffer. You will have coital problems. She will have irritation, PID, pain. All these things we'll have to tell them, the husbands.
One thing more, that if we have diagnosed as a case of a fungal vaginitis, so how long would you like to give the treatment? Till the symptom subsides, or there is some definite tenure that you give the treatment?
Fungal infection is very, 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 very difficult to treat.
I know.
As I said, if we start on fluconazole, it may not be effective. If we start on candidiol or all those drugs, they say it's a 20 days course, but I have seen the patients, even after 20 days course, next month you see they are again coming with it. So
Yes.
again, this comes that we just cannot give one duration of course and tell them, okay, it's fine, you take the course. After completion of the course, after a gap of 3 days, the patient has to come back to you. And we have to again examine the patient, again see, and if treatment is required, maybe 3 months, at times maybe 6 months are needed when it is a very old standing infection. And same is with the male partner. Secondly, we have to check with their diabetic status. If they are diabetic, if they are prone to diabetes or pre-diabetics, then their blood sugar has to be properly controlled. And I tell them, you will not be relieved of your symptoms unless you control your blood sugar. You come back to me after controlling your blood sugar, then only my treatment will be effective. So that's
So
how
it
the counseling plays part.
So you want to say that if it is a fungal vaginitis, you have to follow the patient even after she becomes symptomless.
Yes, absolutely.
And if the husband is not having any symptom, should we continue that treatment for the 6 months for the husband also?
No, first like we have to inquire about that area about from the wife if he has any problem. Then secondly, we do a semen examination and urine culture examination. If they are fine, then they don't need further treatment.
So the husband needs in the fungal vaginitis, how long treatment? For the 1 month or 2 months?
1 month would suffice, I think, and then we can reconsider the situation.
Dr. Supriya?
Yes. 1 month. Usually for 4 weeks, we tell them to take regularly on a particular day, once a week, and then they can stop taking it if they are fine. No need to. If the symptoms still persist with the wife also, then we can extend for another 2 weeks.
We take the things that way around, that the female partner is not suffering at all, and she complains that my husband is having such type of problem. So in that case, what should be our move?
Get a diabetic status check, get semen culture done, urine culture done on urine routine, and urine culture after intercourse. That is better if there are some sperms or some semen into the urine. So if there is an infection, we can catch hold of it. And diabetic status. If it is diabetes, we think about fungal infection. If it is not diabetes, we may think about the bacterial infection. And then the reports accordingly, as per the reports, the treatment should be started.
No, Dr. Anisha, I'm saying that if the female partner is not having any symptom, and only the male partner is having the symptom, should we refer the patient to the skin specialist or andrologist, or we should treat?
At least after first investigation, if we find anything, we can treat. If we don't find anything, it's better to refer them to skin or to urologist.
And at that time, the female partner should be used as a preventive aspect?
Yeah, the condom should be advised to these patients. And in today's scenario, husband may be going out somewhere. You never know.
Yeah, certainly. But you can't say,
you can't
keep
say
it into our prescription that don't go to anywhere else.
We can't even say it.
We can't say this. So we should treat the female partner as well.
Yeah.
Yes.
In that situation also.
Absolutely.
Even if she is symptomless.
Yeah, at least a single course is a must before the preventive measures.
Okay. As you both have said that this is a vicious circle, and if the vaginal pH is altered, so then this infection is very prevalent. So the main cause, I feel like, that it is the alteration in the pH that occurs during menstruation or after delivery, and in the adolescent age group, after menopause, estrogen level goes down and the pH level alters. So how we can maintain the vaginal pH as a preventive measure of vulvovaginitis?
To maintain the pH, we need to, first of all, counsel the patient to maintain proper hygiene. Perineal hygiene is the foremost important point in maintaining the pH. So they should avoid using, they should use single towels. Then the irritant should not be used. Usually the perineal wash, they use some irritant like Savlon, Dettol, those things should be. Then the area should be kept dry. And the proper washing technique, that front to back, should be maintained. So we all need to, after the menstruation, after usually in the adolescent age group people, we need to counsel them to keep proper hygiene. As you saw that the lactic acid bacillus, they all get destroyed during that period. So to restore it, they have to maintain the proper hygiene. The bottom line is to maintain proper hygiene, pat it dry, keep the area dry, wear loose cloth, and proper hygiene is to be maintained in all age groups.
Okay.
So this is the way we can maintain the pH, and then there will be no infection.
I mean, if we educate the
Yeah.
patients in that way, so we can prevent this vulvovaginitis. I think we are running short with our time. So I want to ask a last question to both of you, one by one. Dr. Nisha first. That what is the role of vaginal wash in vulvovaginitis to have the prevention and as well as the therapeutic?
Basically, I would say the vaginal wash are preventive. They cannot be therapeutic. Basically, they maintain the pH of the vagina, of the vulval area when they're using it. So I won't consider it as a therapeutic option. It is a preventive option, and we should advise our patients to use it. And specifically those who are having vaginitis and all, they need it badly.
So you mean to say it is essential? This is essential toiletry in our
Exactly.
in our bathroom. We should do it regularly.
Absolutely.
Vaginal wash. Dr. Supriya?
Yes. So perineal wash with these things should be regularly advised, not only to keep the hygiene, but even if there is some infection, the lactic acid can prevent it, can supplement it, so that the vaginal flora gets, the pH gets balanced.
As a supportive measure.
Supportive. Yeah, and she can be healthy. And so the regular hygiene, that way also you can make it a habit of doing the perineal wash, and then that will lead to no infection. So that way I need to counsel.
There are lot many vaginal wash in the market. So is there anything specific in the vaginal wash, or any of the vaginal wash can be used?
No, rich in lactic acid, obviously.
I think they're all good.
They're all good.
Yeah.
So these are the OTC product. Anybody whosoever is coming your OPDs is asking, is saying that I'm using not many
So and so.
brand name they are telling, and I'm using this. So can we say something about like there is some definite vaginal wash that they can use because of this? Is there any specification?
The thing is, being medicos, we would not promote the OTC brands.
Yes.
So we would write something which is not available OTC.
Oh,
that's such
We have seen people getting better. So if we see we have given certain brand and people come, the patients come back telling, yes, we gained a lot, we are treated. So that way we can promote some. If we think, this really works well, then we can write.
Okay, by your clinical practice, by your seeing the results you are getting with that vaginal wash, you are getting good, so you can write that.
Yeah.
But otherwise, more or less, every vaginal wash is the same.
More or less.
More or less. More or less. So, thank you, Dr. Supriya. Thank you, Dr. Nisha, for such a very good interactive session. And you have given such a good answers. I think it is very comprehensive, and I think you have covered whole of the topic of the vulvovaginitis very nicely. And thank you for being a part of this webinar. And I will give a take-home message to all the colleagues that we should counsel the patient in that way, that we should ask. We should promote them not to have the vulvovaginitis by the preventive measures, like use undergarment should be of cotton. They should not be very tight. They should keep the place dry. It should not be wetty. And if by the way they are wetty, they should change they should be frequent change of the clothes. And they should take a proper hygiene and a proper care during menstruation and after delivery. Adolescent age group and after menopause, they should take care very precautiously because of the low estrogen level. And the vaginal wash should be essential toiletry of our bathroom, so that we should not alter the vaginal pH, and with altered vaginal pH is the main important part to have the vulvovaginitis. Thank you, Dr. Shobit. Now,
Thank you, Dr. Alka, for making it so lively. Thank you.
Yes, thank you.
thank you.
And
Thank
Dr. Supriya.
There is one question from Dr. Pratibha Dikshit from Agra. And can I take up that question?
Yeah,
Yes.
sure.
Yeah. So it was with regards to, I believe, tuberculosis of the cystitis when Madam was referring, Dr. Nisha
Mhm.
Jain. It is, she has asked how to test the tuberculosis of vulva and vagina. So any thoughts on that?
The thing is, we cannot diagnose tuberculosis of vulva or vagina unless and until there is a lesion, and we take a scraping of the lesion and get a PCR testing done. Mostly, if there is a vulval or vaginal tuberculosis, it's starting somewhere in the uterus. So on day 1 of menstruation, we take the endometrial biopsy and we send it for PCR testing, and the PCR reports always they come positive if there is tuberculosis. Secondly is the Montrose test, and thirdly is the temperature charting. We tell the patient to maintain a record of their temperature morning and evening, and it's not that how much is the temperature. We need to see if there is a shift of the temperature, there is an evening rise of the temperature, plus general symptoms in the patient, loss of appetite, cannot work, weakness. So keeping all these things together, and suppose we have done an HVS and we are not getting anything into it, it's absolutely sterile, then we should think about tuberculosis, and I think these are the ways to diagnose.
Otherwise, we have seen a very seldom cases of vulvovaginitis because of tuberculosis.
Right. There is one Dr. Nutan from Delhi, and she has inquired what is the role of tissues to clean locally.
Tissue
Yeah,
paper.
tissue paper probably she meant.
They keep the
toilet
vulva
paper.
dry. Yeah. They keep the vulva dry. That's it.
Yeah.
But it should be
Tissue papers
damped. It
absorb
should
the
not.
liquid.
Pat
So
dried.
it is really very good in case supposing sometimes it happens that the area is difficult to keep dry. So the tissue papers, the soft ones, can be kept in the crease of the thigh, and that can help quite a lot. Yes. But not for a long time. I don't advise that, but the tissue paper helps.
Right, right. Yeah, role of tissue in local vulval cleaning. That is what she meant. Yes, correct. So you have answered that. I believe that you have covered most of the questions which came to us, and it was very much evident from the discussion that it is a very important toiletry, as you all have pointed it out, and it should be a part of our washrooms. And just one question, just on being on a practical clinical front, do the patients really follow this perineal wash hygiene, or when you are prescribing, or they omit it from the buying that when you are recommending that?
They religiously follow it.
They religiously follow it.
Yes.
It is only when they have an issue. But do you think that it should be a part of a hygiene, a normal routine vulvar hygiene?
Yes.
So many times patients come and they tell they're using so and so product. They are aware. At least in Delhi, most of the patients are aware.
Okay. So it is not that something out of the blue that we are prescribing with the patients, and the patients are saying, "Arey, ye kya hai? Why this? Why?"
No.
Of this,
80% of our OPD patients they are using.
Oh, that is great, and they accept it.
Yes.
There is acceptance. There is acceptance.
Yes.
So,
if you forget to write on your prescription, they ask from their own. Okay. Should we use it? Can we use it like this? Now the awareness is too much.
Great. So that the advertorials and all the advertisement which are shown on the television, they help actually.
They're working.
They are working. They're creating an awareness. That is one good thing about it. And of course, you all, as Madam has rightly pointed out, Dr. Nisha Jain, OTC वाला हम लोग नहीं लिखते, हम लोग बेनामी जो जिसका नाम नहीं होता हम वो लिखेंगे. ये अच्छी बात मैम ने बताया. So this is good. So we are not into the OTC. So please. So thank you very much, Alka madam. Thank you, Nisha madam and Supriya madam, for your sparing so much of time today on Sunday. And of course, a week prior when we started the discussion to have this webinar, we have finished in time. We are though 5 minutes ahead of our schedule. So thank you very much. It was a pleasure interacting with all of you. And we wish to have further such conferences, maybe something on a different or say some different topic. So we'll definitely wish back to you. We'll get back to you and invite you for further conferences like this. So thank you very much. Have a great evening.
Yeah.
And, take care and stay safe. That's it.
Thank you. Thank you so
Okay,
much.
thank you.
We had
Thank you.
nice time.
Thank you.
Thank you.
We had a nice time, really.
Thank you.
Okay.
Thank you.
Nice connecting with you, Dr. Alka and Dr.
Thank you.
Same here.
Thank
Same
you,
here.
Dr. Supriya, and thank you, Dr.
Supriya.
Nisha.
Yeah.
Very nice.
We'll meet sometime in future.
Yeah,
Yeah,
sure.
at some conference.
Yeah.
Yeah. Hope so.
Okay. So we're signing out?
Yes.
Okay.
Yes.
Okay.
Thank you, madam. Namaskar. Thank
Okay.
you.
Namaskar.
Thank you, doctors. Thanks a lot.